Is your gut making your life harder than it needs to be? Irritable bowel syndrome, inflammatory bowel disease, and chronic poop problems affect millions, but they're still weirdly taboo. That ends today. Welcome back to the Health Exchange. I'm Dr. Jay Rutland, and I'm joined by Dr. Kumkum Patel, a double board-certified gastroenterologist practicing down the street from me in Orange County, California, who's all about making digestive health make sense. Let's bust myths, break the silence, and talk poop on today's episode. Dr. Patel.
Dr. Rutland.
What do you, so it's going to be good, right? What do you like to be called? What can I call you today? I want to be respectful.
You can call me whatever you want. Dr. Gut Motility, Dr. Patel, Dr. Kumkum, just Kumkum, whatever makes your heart sing.
Well, what's interesting is the first thing you said was Dr. Gut Motility.
Uh-huh.
And I've always found gut motility super interesting. We talked about why a minute ago. But how did you get to where you are? And why did you get to where you are?
So today I got here because I drove
Excellent.
down the freeway.
All right. 405.
But 405,
Yeah,
obviously.
for sure.
But you know, my journey has been a pretty long one. I went to medical school because I wanted to do something with my hands, science just made sense to me.
Mm-hmm.
But I grew up in a very poor background. So the wealthiest people I knew and the smartest people I knew were doctors. So for me, my escape from poverty and my escape from my life was education. And so I graduated at the top of my class in high school. I got a full scholarship. I studied engineering in undergrad.
Where'd you grow up?
In Virginia.
Okay.
And, I was like, okay, what do I want to do with my life? Well, I was like, I have a big enough brain that I can do whatever I want. And that led me to say, okay, I think I really like science and talking to people. That led me down to the path of being like, okay, engineering was good. I did bioengineering in undergrad. And I was like, I can't be stuck in a lab forever, seeing the same people from 9 to 5. I want a lot more stress, and a lot more debt. So hence I went to medical school. And in that process, I had the opportunity to go to St. George's. I went my first year in England, where I got a scholarship, where I met my husband. And I got to travel the world. And when I finished, I did my residency in New York. Mm-hmm. And then we couples matched. My husband and I couples matched. And we came to Chicago. We got separated during the fellowship. So I was a single parent. I was doing fellowship in Chicago. My husband was doing fellowship in Peoria. And then after we were done, we moved to California, which is where I am now.
Nice. And then when did you fall in love with shit?
When I realized it made the most amount of sense.
Yeah.
Through when I was a resident, the funnest, coolest people that I knew were all gastroenterologists. They were definitely the smartest. Not to say that pulmonologists weren't, but the GI guys were like the coolest ones, right? But really, I think the GI tract, makes the most amount of sense in terms of, top, bottom. And it's the most fascinating, I think, right? The gut is the second brain in the body. And we'll talk about that, later. But the gut is the second brain. It really controls the predominant amount of health in our body. So it's really fascinating to me that our gut controls so much of our mood, our immune system, our, everything it regulates. And so as I got older, I experienced my own set of GI symptoms and specifically had an IBS. As I became a first-time mother, I experienced pelvic floor dysfunction and I experienced postpartum depression.
And they're all associated with one another, which is really interesting.
It was wild because I was a first-year fellow by myself when this happened. And I was like, oh my God, there is no one I can ask about this because everyone in my fellowship was male. And one, we need more female GIs talking about this because this is all happening. And so that became, what really drove me to find the gut-brain axis and to really follow that.
That's interesting. Was there a particular story during residency that drove you towards GI? Was there a particular patient story? Is there somebody you remember?
One of the things I distinctly remember was when I was in residency, I was obviously doing, rotations in the different parts of internal medicine. And during my GI rotation, I was in the functional GI clinic and, everyone had IBS per se. I didn't really know what IBS was, but just that it was some kind of an umbrella term. Everyone had issues with pooping. But more and more I realized that the phenotype of the person who's coming in had other issues going on, right? Oftentimes they had pain, they had fibromyalgia, they had anxiety, they had depression. And I didn't make the connection that IBS was a disorder of gut-brain interaction until much later. And so when I remember, I had even said it out loud. I was like, wow, have you noticed how almost so many of these patients have other psychological disorders or are having other things happen with them as well? My attending was like, this is what exactly why you need to learn more about it and focus on it. And that kind of gave me the precipice to do it. Also in fellowship, I learned all about motility. I had my attending was the guy who performed the first oral endoscopic myotomy in the United States. And
What is that?
so peroral endoscopic myotomy is a procedure where you go in with an endoscope. That's the camera that goes down the food pipe, and it actually cuts the circular layers of muscle in the food pipe itself in order to release the pressure that's being caused in a disease called achalasia. Okay. So most of the time, achalasia used to be treated with surgery. They would cut people open, they would release the pressure, and that was that. But this guy, Dr. Stavropoulos, he, did the first poem in the United States after they had done them in China and Japan. And it was phenomenal, right? Like these people flew from all over the world to do it. And that's what my research was end up being. Hence why I did a sub-fellowship in motility and fell in love with it.
Wow. That's a fascinating story. I mean, honestly, like it's really interesting to hear a little bit of parallel in my life with your life in terms of how you evolved to be where you are sitting like right now. So when I was in medical school, right, one of my favorite GI teachers was this guy named Dr. Rao, who you know,
Yes.
right?
Yes.
Dr. Rao was a motility specialist
Mhm.
at the University of Iowa at the time. He's now at Georgia.
Yeah.
We talked about this.
Yeah.
What he taught me was that if your interest was led by passion and energy, you would become a continued learner and what the world calls an expert. I call it a continued learner. They call it an expert, whatever it is. But that's one of the things he taught me. But the way that he did this is I remember a lecture one day, and he was so passionate about this. He started talking about this Bristol stool chart. And the Bristol stool chart, and you're going to explain it to us, but it's basically like what your poop can look like, right?
Mhm.
What color it is, the shape of it, all of those things combined. And he had like a laminated card of the colors of the shape and just the science that he brought into looking at shit was just crazy to me. And I
Mhm.
absolutely loved it and I will never forget it. But tell me about it. Tell me like how you use this chart.
Okay, first, for those of you who don't know, the Bristol stool chart is a chart that scales poop from 1 to 7. 1 and 2 being on the constipated side. 3 and 4 we'll talk about is on the normal side. 5, 6, and 7 on the more loose or diarrhea side. I love to talk about the Bristol stool chart in forms of candy because when you come to my clinic, I want you to describe your poop based on foods because it's the easiest way to talk about it, right?
Mhm.
Do your stools look like milk duds, right? If it's coming out looking like rabbit pellets or milk duds, it's likely a Bristol stool type 1, right? Because there's not enough water to allow those little pellets to congeal and make a nice looking what we call a Snickers bar, okay? I want everyone to poop a Snickers bar every day, okay? That's your Bristol stool form. A little bit less than that, if they are, formed milk duds and it looks like an old Babe Ruth bar, that is a Bristol stool type 2. Okay. And if it's a little bit more formed than that, 3. But again, you're trying to get to the gold standard, the Snickers bar, right? The smooth, it's got edges. It's, you can see the beginning and the end of it. It's perfect.
So
Okay.
the Snickers bar. So like when you're sitting on the toilet, you're
Yeah.
going to the bathroom.
Uh-huh.
Sometimes if I don't know if this is a Snickers bar or not, but it'll like break off.
Uh-huh.
And you're like mad.
Yes.
Because you have to like spend a lot of time wiping your butt.
Uh-huh.
Right? When that happens. Is that normal or is that not normal? It shouldn't break off like that.
So if it breaks off, it might be on the softer side, but because usually those clumps should stay together, right?
Yeah.
Until it hits the toilet. And in case it should stay there. But if it breaks off immediately after hitting the toilet, it likely has too much water in it and might be a Bristol stool 5, 6, or 7.
Yeah, see,
It's getting towards mush and oatmeal.
sometimes for me, like I feel like the perfect one is like sometimes it just slides right on out. It's like kersploosh, and it like hits that water,
Uh-huh.
and it goes straight through it. It
Yes.
doesn't even splash up on you, and
Correct.
you probably don't even really have to wipe yourself, but you
100%.
do
Yeah,
because
yeah,
you're
yeah.
polite. You
Yeah,
know?
but that is the gold standard. You want every day to be a slide on out.
The slide on out.
Yeah.
That's what you want.
Yeah.
So, and that's a 4. So a 4
That's
is
a
a
4.
slide on out,
Yeah.
perfect dive, no splash,
correct.
Olympic 10s across
Correct.
the
And
board.
you feel empty afterwards.
And you okay? All right.
Right? That's the big thing, right? Not only did you have a Snicker bar come out,
Yeah.
but it left you feeling empty.
Okay. All right. And so then after the Snicker bar, you've
Yeah.
got what?
So after the Snicker bar, you've got clumps that are too loose. They've got too much water that was not absorbed by the colon. So they're, softer pieces. They're like blobs. Then you're getting towards like oatmeal and then like straight water, right? That's
Yeah.
the Bristol stool type 7, which is diarrhea.
Right. Now, just as a general rule for, let's say, parents, when should you be worried if your kid is having too much loose stool? Like, how long do you give it before they probably should be medically evaluated?
It depends. It depends on what your child has eaten. If they just had, street food or, poorly cooked meat, that may be, a gastroenteritis infection, right? And so you want to kind of just let it run out. And as long as they're not having, major fevers or chills and things like that, you can kind of just let it run its course. And that's for children, but even for adults, right? If you're having loose stools, again, it's either because you have stress-induced IBS or you may have a food-induced gastroenteritis that's making the transit of the poop faster and making it come out looking like water, right? And so only if it's associated with alarm symptoms like the fevers, the chills, feeling badly, having severe abdominal pain, do you get worried that warrants an evaluation.
Now, I'm not a guy that always likes to talk about color, but
Oh, yeah.
stool has a certain color, and there's also a little bit of color on this chart. Tell me about the different colors of stool and what they could potentially mean.
Yeah, totally. So you want your poop to look nice and brown, so yellowish brown, okay? That's your gold standard, right?
Like this chair?
Yeah, a little bit darker than this.
Okay.
A little bit darker than this. So you want that to be your gold standard, okay? And if it's got red in it or a red on it, that's a bad side. Red in it means that there is bleeding from your colon, like the walls of the colon, and you should be concerned that there may be inflammation. If there's poop and blood on it, it could be that there's hemorrhoids or something else that's attaching blood cells onto the top of the poop, but the poop itself is normal. If the poop is more green, it may be bile, which is a liquid that's formed in the gut, or it could be green food coloring. If the stool is very pale or clay colored or kind of looks like, like the old pastel stuff that we used to play with as kids, that means there's maybe a blockage in your liver or gallbladder and the biliary ducts. And that's preventing the pigment, because pigment of poop comes from bile. Okay. And so there's something called stercobilin, and that is what actually gives pigment to poop in itself. And
And
comes
that's
from
a molecule you're saying, like
yes,
stercobilin. Okay.
yes. And so that is what gives color to poop itself. And so that comes from red blood cell and biliary breakdown. And if there's a blockage in your biliary tract, you can get pale poops. Okay. If you get black tarry poops, that's also a problem, because that means that you could be having a bleed somewhere in your digestive tract, specifically somewhere higher up, maybe the stomach, maybe the small intestine. And the reason why it's black is it's had some time to get digested through, and it's, taking its time to transverse, rather than being bright and red, where it means that it's coming from likely somewhere lower down.
So most of these individuals out here aren't going to know how we originally met. I mean, obviously, you meet social media physicians during the pandemic, you talk and things like that, hear about each other. But we just did a scrub modeling, whatever you want to call it,
Fashion show.
a fashion show for a friend of ours. Like
Yes.
Shav and I went to college together.
Yeah.
And I met you in person there for the first time.
Yeah.
And the other thing that we do is we also consult for one of the same company,
Yes.
right?
Yes.
And this company has a product that operates within the disease state of eosinophilic esophagitis,
That's
right?
correct.
Tell us about eosinophilic esophagitis, what it is, how it affects people, that kind of thing.
Sure. So EOE for short, eosinophilic esophagitis, is an inflammatory allergic disease of the food pipe where food acts like an allergen. So similar to how allergies, like seasonal weed and pollen, all that stuff acts in the food in the windpipe. food allergens can act like that in the esophageal barrier. What it does, it disrupts it. Okay. So basically, the food pipe's like, ooh, there's something that has entered our body that we don't like. And so it releases something called alarmins, right? It gets alarmed and it sends the immune system to actually secrete these little interleukins, which then triggers a response to send more cells called eosinophils and mast cells and Th helper cells. And it causes inflammation, which means that these things start to build up in the lining of the food pipe. And it also causes fibrosing or scarring down in the lower levels of the food pipe itself. And it's a disease that just continues as you get older. And so over time, this causes more scarring down and narrowing in the food pipe. And this can actually cause for food to get stuck, not go down very easily. And not only that, the longer the disease happens, it actually causes muscular dysfunction as well. So a lot of people end up having not only food get stuck, but feeling that food is not going down very easily because there is esophageal muscle remodeling. So they get dysphagia, which is the medical term for it. And so this medication, there's a medication that's come out that helps in EOE that helps to block this inflammatory cascade and kind of prevents the antibodies from coming out and kind of slows down this remodeling pathway. So
Yeah, and one of the things that people don't often think about and physicians don't often think about is that when you think about the body in general, right? There are these cells that are like the white picket fence of your body, right? And they're called epithelial cells. Now, the way that I think about it is you have epithelial cells that are in constant contact with the environment, right? Your upper airway, your lower airway, obviously, because you're snatching the environment with every breath. And then your food pipe, your upper food pipe, your lower food pipes, right? Because you're eating food all the time and different types of food. And food is just another antigen. Just like the different molecules in the air, food is the same thing. And so what's actually super fascinating is 64% of the patients that she sees that have eosinophilic esophagitis also have asthma.
Mhm.
And so thinking about the epithelium is extremely important because there are other conditions and other diseases that also affect the gastrointestinal tract, right? You've got Crohn's disease, ulcerative colitis. And the reason that I know those is because as a guy who's super interested in immunology and has an understanding of cytokine biology, people that have Crohn's disease or ulcerative colitis, inflammatory bowel diseases, we call them, they also are going to have autoimmune lung disease, which is
Yep.
all my clinic is. My clinic is just autoimmune lung disease. So I see interstitial lung disease all the time. And I have a number of patients that have both IBD and an autoimmune lung disease. And you can understand that both ulcerative colitis and Crohn's disease have a loose affiliation with certain cytokines, right? There's cytokine signatures. Like if you look at Crohn's disease, and I'm sure you know this, Crohn's disease is, you guys have heard me talk about inflammation before. There's type 1, there's type 2, there's type 3 inflammation, right? And there's different cytokines that are responsible for the different cellular signals there. Crohn's disease is associated with type 1 and type 3. Ulcerative colitis may be associated with type 2, but Crohn's disease is throughout the entire gut.
Mhm.
You can have inflammation throughout the entire gut, right?
Correct.
And ulcerative colitis is really just the colon.
The colon. Yeah.
But the biggest thing about ulcerative colitis is the risk of,
Colon cancer.
which is really common, right?
Very,
nowadays.
very high. 8 times as much. And so, well, that's the exact thing. You've disrupted the barrier in the intestine, and you've also disrupted the microbiome, right? The bacterial composition in the gut. And with the disruption of both, you are leading to changes in the health of the cells that are in the colon, which is then causing for it to form these abnormal tissue growths, which is called polyps. They're called adenomas. And if left for a long time, they can develop into colon cancer.
It's really annoying to me when I hear this on social media, okay? Because this is interpreted by so many people, and I just don't, everybody has their own interpretation, and half the time I'm like, dude, that's not this. But everybody says gut health.
Oh.
Yes, thank you, right? So if somebody comes into your office and they're like, oh, I want to just improve my gut health,
Uh-huh.
like, how do you take that? What do you say?
Well, I will say now there's a lot of gut health experts who are clearly making a lot more in their bank account than I am, even though I did 15 years of training after high school. So, I think the world outside of medicine views gastroenterologists as gut disease experts and wellness people as gut health experts. And I think it's our job as gastroenterologists to really learn and be able to disseminate that information about gut health, because it means that it is about figuring out how you can optimize your gut microbiome, how you can optimize the gut-brain axis so that your gut is preventing diseases from happening.
Gut microbiome.
Yes.
Not everybody knows what that means.
Yes.
Tell me what that means.
So the gut microbiome is a conglomeration of bacteria, viruses, even parasites and fungi that live together in our gut, and they are responsible for a lot of different things, like making immune cells, making mood hormones, telling our bodies that they're full. And so they are doing a lot of different activities or fighting infections. And so the gut microbiome is something that is altered, but something that needs to be optimized so that it can do the best for you.
Now, one of the diseases that you love to treat, that you're consulted for a lot, is IBS, or
Yes.
irritable bowel syndrome.
Yes.
Tell me about irritable bowel syndrome, gut microbiome, gut-brain communication. Tell me about how that relates to irritable bowel syndrome.
Yeah. So irritable bowel syndrome is considered a disorder of gut-brain interaction, right? Before it used to be called, a functional GI disorder, which no one really knew what that meant, right? It's a disorder of gut-brain interaction. And there are 5 main things that people really believe is happening. They think that it's either because of a change in the underlying bacterial composition that is causing this disorder of the gut-brain interaction. There's a miscommunication between the gut and the brain. There's some type of abnormal immune activation. There's some type of nerve sensitivity that's causing those symptoms. And so that is all or it could be after an infection. So that's caused the dysbiosis or the change in the microbiome. So irritable bowel syndrome, usually you see people have abdominal pain for, a few months associated with the change of their bowel habits. And as long as they don't have another full disease process, such as cancer or inflammatory bowel disease like Crohn's or ulcerative colitis, and they don't have any alarm symptoms, that's likely is what the diagnosis that they receive. The problem is that there are so many diseases that mimic irritable bowel syndrome that people either get misdiagnosed or they get mislabeled.
Right.
So, irritable bowel syndrome is something that's actually quite complex. And because it's a disorder of gut-brain interaction, it's important for us to, really address both things, the gut as well as the brain.
And so when you are defining the different types, there's what? There's like diarrhea predominant, constipation predominant.
And
Mixed, and then some like...
Unknown.
Exactly.
But unknown is unknown.
Is unknown. Okay. So when a patient comes in to see you and they have bloating and abdominal pain, I find it rather difficult at times because that can represent an inflammatory bowel disease in which you need to do an upper and a lower endoscopy to try to rule out inflammation versus something like IBS, which is thought of as benign, but it's not benign. So how do you find comfort knowing that you don't have to be so invasive on all these individuals? Like what is it that you evaluate or that you do to be able to separate when you're going to be invasive and when you're not?
So I think it's a case-by-case basis, right? So the guidelines, right, if you look in the American College of Gastroenterology guidelines, they state that as long as people have 3 positive criteria from the Rome Foundation, which is abdominal pain for the past 3 months, a change in their bowel habits, and a change in the character and stool of their bowel habits in those last 3 months, along with no alarm symptoms, no fevers, no chills, no night sweats, no drop in their blood count, and they have, no other major symptoms going on, 90% of the time, you can say that these symptoms are irritable bowel syndrome, okay? But that being said, people have concomitant things going on, right? Oftentimes they have weight loss because they're afraid to eat, right? Or may have some rectal bleeding, but they may be from hemorrhoids, but something else, right? Or they have loose stools and they have a family history of something. So these oftentimes warrant a further evaluation. And because again, it's easy to quickly label somebody. We have transference, right? You meet somebody, you're like, oh, this person likely has IBS because you assume, okay, if they've got any psychological disorders or they have a lot of pain, that you want to mislabel them rather than really understand their gut-brain axis, what's going on, and make sure that you're ruling out things like celiac disease, bacterial overgrowth, if they do have microscopic colitis. There's a lot of things that mimic IBS and it's not IBS. But as long as you've done a thorough workup and you can say for sure, then yes.
So things that mimic IBS include, you said celiac disease.
Yes.
Tell me what celiac disease is.
So celiac disease is where you've got an autoimmune disease where there's antibodies that are attacking the lining of the small bowel. And it's because the small bowel has been exposed to a protein called gluten. And unfortunately, the body thinks that this gluten is a foreign protein. So inadvertently, the antibodies come and attack the lining of the actual villi in the small bowel. And this can cause flattening of them. And this causes malabsorption of things that include gluten in them. And so people end up getting a lot of bloating, a lot of diarrhea, a lot of loose stools. And because of that, they also can get anemia because they are not absorbing the iron, which happens in the first portion of the small intestine. So a lot of celiac patients come in iron deficient and they just can't figure out where their blood is going. They're like, well, I'm not pooping it out, and my menstruation is not that heavy, and I don't have sickle cell, and my kidneys are working fine. So where is it?
Yeah.
Right? And it's like, oh yeah, it's just not being absorbed very well. And it's because the villi in your small bowel are not absorbing it because you've got underlying celiac disease.
And then you also mentioned small bacterial overgrowth, or what is it?
SIBO,
SIBO is what they call it now.
Yes.
What is that?
So SIBO is small intestine bacterial overgrowth, and it's because you have something called MMCs, migratory motility complex. This is like the little waves, okay? This is like the little broom that's in your stomach and your small bowel that moves debris and food particles and everything along every 90 minutes or so, okay? And that's what keeps everything kind of just moving. So whether you're eating or not, this wave is happening, okay? And in some people, it's not going very often. And sometimes it's kind of going a little bit backwards. And this is causing a translocation of bacteria. So sometimes bacteria can go from the colon backwards and go into the small bowel. Okay. And this can cause a bacterial overgrowth. So you've got colonic bacteria, which should not be there in the small bowel, which then can cause an overgrowth of certain bad bacteria and cause symptoms like bloating, loose stools, things like that.
And how do you diagnose that? It's a breath test?
So
or
that's
something?
a breath test.
Yeah.
That's correct. So it's a breath test where you drink a liquid called glucose or lactulose, and you breathe into tubes about every 20 minutes or so for a total of 180 minutes. And it looks at hydrogen sulfide, and methane. And so the methane ones are for people who end up having a correlation with constipation, and the ones who have hydrogen sulfide usually have diarrhea.
Got it. So small bacterial overgrowth,
Celiac
disease.
Mhm.
There was, and other mimickers were inflammatory bowel diseases.
Yeah,
And then you said microscopic.
microscopic colitis.
Yes.
Yeah, so
which
that's
is an IBD.
Exactly. It's a microscopic version of Crohn's and ulcerative colitis, and they either have collagen or lymphocytes in the lining of the colon. The problem is that under colonoscopy, the colon looks normal.
Got it.
Okay.
So one of my pet peeves,
Yeah.
GI,
Yeah.
is the gastroenterologist will literally rule out IBD because they just look at the colon. They're like, looks normal. They don't have IBD.
Yeah.
I'm like, bro, listen. Like, I love you. I think you're Jesus. That's great. But like, hold on a second. Can I get a biopsy?
Yeah.
Can we look at some cells under the microscope?
Correct.
And you can tell me that there's no inflammatory cells there?
Correct.
That is like the second biggest pet peeve I have of GI.
Mine too. Because when somebody brings me their colonoscopy report, I'm like, let me look at that. And they're like, normal colon. And it's like 6-month withdrawal. And I'm like, okay, so you had a journalist, basically a photojournalist, go in there and take some pics and then come back out. But they didn't evaluate to see if there's microscopic colitis where your colon looks normal, but there are lymphocytes or collagen deposits in the lower, deeper cells of the colon. So, that's completely missed. And that could explain very well what's happening. Or you could have quiescent or quiet ulcerative colitis, right? So maybe it's doing well and you just haven't caught it. Or it's very, very minimal Crohn's disease. And because it's a patchy disease, maybe you didn't take biopsies all throughout like you should, and now you missed it.
Yeah, I mean, it's just, it's so frustrating sometimes because for me, and again, this is one of the issues that I've been asked about from the company that we consult for, is how do we get gastroenterologists, common gastroenterologists, to think about immunology? Because there's this separation where you have your IBD GI docs, the docs that care about inflammatory bowel disease and the immunology, and then you have your, I don't want to say average. You have GI
Your
docs.
bread and butter.
Your bread, I guess bread and butter, whatever.
But bread and butter is actually IBS because it's everything that's non-interventional, which is non-pancreas, non-biliary, right? Because again, these things all require a separate additional fellowship, right?
Yeah.
So after your 3 years of GI, a lot of people do a 4th year where they do advanced biliary techniques where they, learn how to do stenting in the liver and the pancreas and all that, right? People do an esophagology fellowship now. There's motilities and things that you could do in the upper tract, right? There are people who do bariatric GI, and now more and more people are doing the neurogastromotility tract as well. And so people are becoming sub specialized within the GI tract. And so if someone else has a major pancreatic thing, I'm like, ooh, That's great. I know where the pancreas is and I know what it does. But I really want you to see a pancreas specialist because one, it's also having to do with the instrumentation of it.
Right.
Because if you're going to have to do, an ERCP, I'm not ERCP trained.
Right.
So as much as I want to do everything and get all this imaging, I would rather you go to a specialist who's going to be able to do something about it if you do need an intervention.
Now that makes sense to me. It just never made sense to me that a GI doc that did upper and lower endoscopies would not actually biopsy the colon or the small intestine.
Yes.
Or I'll send a patient that has asthma and says they get food stuck in their throat to like a friend of mine is a GI doc and he'll do the upper endoscopy, right? Obviously, I'm looking for eosinophilic esophagitis and he'll biopsy the small intestine and the stomach. I'm like, bro.
You need to start sending me more patients.
That's what it sounds like. I mean, like, can you please like biopsy? It's just something that's just really
It's 6 biopsies. Okay, for those gastroenterologists that are listening to this, you got to take 6 biopsies, 3 in the distal, 3 in the upper to get the diagnosis of EOE. So don't forget. It doesn't matter if it's normal or not.
Right. Now it's time for What's the Buzz, presented by BuzzRx. Every week I answer a health-related question from one of our viewers. This week's question, how does Prilosec actually work? Is it stopping stomach acid completely? This is a great question. Prilosec, or omeprazole, is actually a prodrug, meaning it needs to be activated. Here's how it's activated. Omeprazole, once it reaches the stomach is full of protons, which means that it has a lot of acid. Protons equals acid. Omeprazole is activated by this acid. Once it's activated, it actually inhibits a proton pump located on parietal cells of the stomach. So that means that less protons, or H+, gets put into the stomach lumen. So it reduces the amount of acid being pumped into the stomach lumen. When it does that, it reduces some of the symptoms of too much acid. That's the buzz. If you have a question, email us at healthexchangepodcast@gmail.com. Thanks again to BuzzRx. Look up your medications on buzzrx.com or the app to see how much you can save. The other thing that you do, right, we talked about IBS, is you do a lot of motility.
Yeah.
Tell me about gastric motility, and then we're going to transition into a common therapy which people are taking that's affecting gastric motility. But tell me about the gastric motility part of your life.
Yeah. So motility, I do esophageal motility and I do anorectal motility as well. So esophageal motility, if anyone has trouble swallowing, they feel like something's getting stuck, whether it's in their throat, whether they feel like it's in their food pipe, whether it's not going down, we look to see if the muscles are not moving well enough, if they're spasming, if they're moving backwards, if they've got too much of the pressure at the bottom of the food pipe called achalasia. So we're looking for all of those. And there's specifically something called esophageal manometry, which can help us look at how someone swallows 10 sips of water. And we can check the pressure in their food pipe and how it gets pushed out. Okay.
Nice.
There's also something called anorectal manometry, and we look to see how people poop. Because there are people who not only have an issue with the poop moving through the colon, but the poop exiting the colon, right?
Yeah.
So constipation is a twofold issue. Well, actually, it's a threefold issue. But in anorectal manometry, we
What are
look
the
to
three
see.
folds?
So one is slow transit.
Okay.
So just moving real slowly. Another one is normal transit, but you just don't have enough fiber.
Yeah.
And the last one is pelvic floor dysfunction. So it's an exit issue,
Got it.
right? So if you think you have an exit issue, it's because the muscles in the pelvic floor are not actually coordinating properly to allow it to relax, let the poop out, and then close. So in these people, sometimes it's miscoordinating, only a little bit of it's opening. And these people usually come and complain, being like, oh, you know what? I sit on the toilet, I do a whole dance routine, I go from side to side, and then I lift up my leg, and then I hold on to the side, and then I can have 3 pellets coming out. And I'm like, wow, you have choreographed it down to a T, right? And so I'm like, okay, how many times do you like, oh, I do that twice. Once after I have my coffee, and then once, after I have my breakfast. I'm like, oh my God. So like, these people have pelvic floor dysfunction, and using an anorectal manometry, we can understand what their sphincter muscles are doing. Is it that they're actually preventing their own poop from coming out, which is called paradoxical contraction? They're holding their bottoms too tightly. Or is it that their pelvic floor muscles are not strong enough to push the poop out, right? That's gotten weaker, right? They've had a baby that was 12 pounds and their pelvic floor muscles carried that baby for 9 months. And now pushing out that baby, they're like, okay, great. Now their pelvic floor muscles are a lot weaker. So they may not have the strength to push that poop out, right? So understanding which of the muscles are weak and what is needed is what anorectal manometry is helpful for.
So I do have a question for you.
Yeah.
And I hope you don't find this question offensive, but people that are having anal sex,
Mhm.
will anal sex affect their ability to poop?
It can. So if you are doing anal sex without there being some type of, one, lubrication, or two, there hasn't been training on insertion, right? So you're going from zero to something much larger immediately. That can cause tearing of your sphincters, your sphincter muscles, right? And that can give you incontinence or loss of the ability to control your bowel movement, right? And so that's why there's dilators and things like that available, right? Or beads, so that you can allow your sphincter muscles to be used to the size and do something called accommodation. You want those muscles to soften, and it's like stretching, right? Like
Yeah.
you're not gonna be able to do a split if I just say go. You know
Yeah.
what I mean? So same thing. You want to lower yourself and learn how to stretch it out in order to prevent tearing from happening.
Other things that I think people have gotten a hold of in the GI realm are probiotics, prebiotics. What are those? What does it mean? How does it contribute to human health? Well, how do you explain that to your patients?
Yeah. So I think there's so much confusion around just the words themselves, right? So prebiotics are fibers that you eat. So like think about your kale, your broccoli, your garlic, your onions, right? These are prebiotic fibers, and they are feeding probiotic bacteria. Okay. So probiotics are bacterial strains that live in our gut. Certain probiotic bacteria have certain jobs, and certain ones of them have a greater role in our microbiome than others. And by making sure you're eating enough fiber, prebiotic fiber, you can feed good probiotic bacteria so that they can do their job,
Yeah.
right? They can make short chain fatty acids, that's their byproduct, which can then tell our brain, hey, we're full. Or it can tell the immune system, hey, we need to make immune cells. Or it can say, hey, we need to make our happy hormone serotonin, right? So all of these things depend on our bacteria to function and communicate with our brain up here. And so we need to feed that bacteria with food, right? And that food is prebiotic fiber.
Now, a lot of people are saying, if you have abdominal pain, you have this, and they'll be like, oh, you just need to take more probiotics. I mean, like, when do you recommend them to patients? Is this something that a healthy person who has no medical issues should be taking every day? Or is this something that, if somebody has, I don't know, bacterial overgrowth, or for somebody has IBS, constipation IBS, or diarrhea IBS, should they be taking probiotics? When do you determine when somebody should be taking? What are the evidence-based indications for
Yeah.
probiotics?
So let's talk about that first.
Yeah.
The guidelines are so fluid, right? They're ever changing. And so like back in the day, everyone poo-pooed probiotics, but there's more and more and more data coming out that
You
probiotics
just say everybody
Poo-pooed.
food.
Poo-pooed. Of course.
Good.
I've got shit jokes all day. All right. Poo-pooed. So one is in prevention of antibiotic-induced diarrhea. There is some data to say that it can help prevent or be used after antibiotic-induced diarrhea. The probiotics can, okay? But
After, not during. So, like, if somebody has C. diff colitis,
Mhm.
should I be treating them and giving them probiotics?
So yes, you can do them concomitantly. And in people who have had a initial episode of C. diff, to prevent the recurrence of it, they specifically say that you should take probiotics that contain Saccharomyces boulardii. That is a strain of bacteria that has been studied to prevent recurrence of C. diff. Okay. There's also an inflammatory bowel condition called pouchitis, where an anal pouch has been created after a colonic surgery in someone who's got Crohn's. And because there's not a lot of good bacteria that's just being in that part of the colon, there's some evidence to say that probiotics can help maintain a healthy colon in pouchitis. Okay. Now, there's not a lot of great data in terms of which probiotics should be given as a silver bullet to help in IBS patients. Yes, there are ongoing studies that certain strains can improve the microbiome and help in IBS patients. And, there are ongoing studies. There are ones with, you see the ads for Seed. They've got 24 strains that are being studied for irritable bowel syndrome, and they're showing that these strains can improve the intestinal permeability, right? That's that's the scientific name for leaky gut.
Yeah.
Okay. So leaky gut can be improved by taking probiotics. Can the healthy person benefit from it? Yes. Can the IBS person benefit from it? Yes. Is it currently an indication to take it? We can't just say as a silver bullet, everyone should take it, because it's much more complicated than that. We need to concentrate more on the strains of the bacteria rather than saying this probiotic is it. This silver bullet helps everybody.
Right.
Okay. So that's the problem with probiotics. But if you're getting a diverse range of foods, then you likely are introducing different probiotic bacteria into your gut. Like if you're eating kimchi or sauerkraut, or you're having kefir or yogurt, that has different strains of bacteria, right? And so by eating those, you're introducing that to your gut. So likelihood of you needing an additional probiotic is not as much as if you were someone who had a very plain diet.
So with that being said, saying is, listen, we have to take this case by case.
Correct.
Right? We can't just go around saying everybody should take probiotics or everybody should take prebiotics. This is something where, listen, if you want to take them, probably not harmful.
Correct.
So by all means, go ahead.
I will say caveat. Caveat, if you are immunocompromised, if you are on cancer drugs, right? If you already have SIBO, taking additional bacteria when you're immunocompromised is likely not going to be well, because you've got an immune system that can't fight off infection. So giving it a large dose of bacteria might not be the smartest, right? So cancer patients, not so much. And also people who've got SIBO, introducing it to them while they have active SIBO also likely won't help their symptoms. So you should treat the SIBO first, the underlying issue that's causing the SIBO, and then introduce the probiotics to them.
All right, so listen, I got a bone to pick with GI docs. All right, and this is my bone to pick with GI docs.
Okay.
And you're going to tell me that you're absolutely wrong. We can totally do that because there's evidence to support it. All right, here's my bone.
Okay. There's only one bone?
Only one.
Okay.
I mean, we already talked about the second one.
Okay, fine.
All right. So in the intensive care unit,
Uh-huh.
and you have an upper GI bleed,
Uh-huh.
every GI doc on the planet
Uh-huh.
says, I need the patient to be stabilized first before I come in and scope. And they especially say it from the hours of 9 p.m. to 4 a.m.,
Mhm.
right? Those are the hours in which they say it.
Mhm.
The patient needs to be stabilized. How am I going to stabilize the patient when they're bleeding? They're bleeding, for God's sakes. Like, I can give them all the blood in the world, but they're fucking bleeding. That's why I called you, bro. Like, get up, come in, put the clip in so that way the patient can stop bleeding. Now, please tell me there's evidence to support. And there was a paper studied that randomized people between the hours of 9 p.m. and 4 a.m. that if the GI doc did not come in at that time, the mortality was the same as if they did. Tell me I'm wrong to be upset when that happens.
You're not wrong to be upset. This is a lifestyle question, Dr. Rutland, where these physicians are like, you know what? I got to work tomorrow. I'm going to be working 7 days straight, and I'm going to maximize the next 6 hours of sleep. And this patient is going to be stable because they're in the capable hands of the ICU doctor that is going to give them IV fluids, some packed red blood cells.
20 units of packed red blood
20
cells throughout
units of
the
packed red
entire
blood
night.
cells. He's going to put them on epi drip. He's going to put them on levo drip. He's going to put them on every drip so the blood pressure looks good. The anesthesiologist is going to sleep so that when he pushes that propofol tomorrow morning, he's going to feel real good after his breakfast sandwich. And we can all do that one well.
There's some common GI myths that we hear about. Now, what I'm going to say is I'm going to say the myth. You're going to tell me the science.
Okay.
What we call this is I've got the myths. You bring the science and the evidence.
Okay.
Cool? All right, here we go.
Okay.
Fiber fixes everything and gives you perfect poop.
Half true. Fiber fixes a lot of things. It feeds the bacteria in our gut and allows for transit to be altered. Whether if it's too much transit, if it's too much fiber, then you can get diarrhea. But if it's sufficient amount, then it'll help your stool firm up and you'll have those perfect poops.
Yeah, and there's soluble and insoluble fiber.
Correct.
Right? The soluble fiber can lower your blood sugar, lower your cholesterol.
But will
Insoluble
constipate.
fiber. Right.
Yeah, insoluble will make it go through faster.
Make it go through faster.
Correct.
You get that perfect poop where you don't even have to wipe yourself.
Correct.
All right. Second myth. Probiotics fix everything.
Another myth, false. Probiotics fix a lot of things, but not everything. If you are immunocompromised, it can become an overwhelm. Probiotics are really pills that we have created of certain strains of bacteria, and they don't contain everything, right? So, a lot of probiotics can't contain a bacteria called Akkermansia. And Akkermansia now is just by itself and its own probiotic because it is something that helps to maintain the mucus lining of the gut. So now by itself, Akkermansia is found. The pendulum probiotic, people have created Akkermansia in a strain by itself. So not all probiotics are created equal, and they don't all fix everything.
If there's anything I hope what you guys are taking away from this particular episode is the fact that you've got all of these molecules that interact with the environment and interact with each other constantly in communication, which can lead to physical manifestations, not just of illness, but physical manifestations of health. Like what you just heard her say right there is this bacteria actually stimulates an inflammatory response, which leads to mucus production that is healthy for the gut. And so just understand that your body's in constant communication, and this is what leads to health, but it can also lead to disease. Another myth, irritable bowel syndrome is just anxiety.
Ooh, myth for sure. That is all false. Irritable bowel syndrome is a disorder of gut and brain interaction. So, stressors from the brain, like psychological stress, physical stress, can cause your gut to be altered, the motility to be altered, and how you perceive pain and how you perceive bloating. So, it is a disorder of gut and brain, and we have to work on both to fix IBS.
Another myth, poop should always be once a day.
Ooh, normal poops can happen anywhere from 3 times a day to 3 times a week. So, as long as you are evacuating and feeling empty after you poop, you're doing fine.
You're good. Another myth, if you're not bleeding, it's nothing serious.
False. So, blood can obviously just be hemorrhoids, or it could be inflammatory bowel disease, it could be cancer, it could be rectal cancer, and it always warrants an evaluation with a colonoscopy.
All right. Another myth, shit don't stink. Poop shouldn't smell bad if you're healthy.
Oh, no, all poop stinks. I mean, I have smelled it all, okay? And I cannot tell you once that someone's smelled like roses, even though we all think that our shit don't stink. No, but it does. It does. Everyone's does. And it's a fermentation of, byproducts of what you've eaten, right? So if you're eating foods that contain a lot more sulfur, it smells like rotten eggs. But that's because it contains sulfur, right? Or if you had too much protein, right? If you're like on a super keto diet, you can expect your poop to smell like sulfur. So expect that, and that gets stinkier. So but you know what? I've yet to, smell anyone's that smells like roses. So no.
It's totally normal to bloat after eating every day.
True, it is normal to bloat because once you do eat, your body does something called accommodation, but you're not supposed to bloat a significant amount. It depends on what you eat. Certain fruits and vegetables contain a non-digestible sugar, and they're called FODMAPs, okay? And because they don't get digested in the small bowel, they go to the colon and ferment and cause gas, so you end up bloating after eating.
One of the things about medicine that I hate is all the acronyms.
Oh, yeah.
What the hell is a FODMAP?
A FODMAP is a fermentable oligosaccharide, disaccharide, monosaccharide, and polyol.
And what does ferment mean?
Ferment means to break down and produce gas.
Cool. So, again, a lot of these times what you guys are hearing, what you're going to hear online is you hear people say, oh, just try a low FODMAP diet. And I find it hilarious because the people that are offering that advice don't even tell you what a FODMAP diet actually is, right? So if I were to ask you what's a low FODMAP diet, what does that look like?
So a low FODMAP diet is trying to have fruits and veggies and grains that are lower in these fermentable sugars. Okay, so these fermentable sugars are naturally occurring. So think about like in cabbage and kale and all that, they have something called fructans. Okay, fructans are not broken down in the small bowel. So when you eat like a cabbage or a kale, you likely feel a lot bloated, right? And you fart a lot. And so it's because it's going to the colon where it gets broken down by the bacteria there. So there are other non-broken down sugars called polyols, right? You think about like your fake sugars. They have anything that ends in OL is those fake sugars, right? And so those are all things that are high in FODMAP. And when people eat them, they can cause bloating.
Farting.
Uh-huh.
How do people generate farts? Is it gas production from bacteria in your bowel? Is that?
So farts are produced with two things: transit of gas that's normally there and production of whatever is being fermented in the gut.
So farts are healthy.
Yes, you should fart.
So you should have no problem farting in front of your spouse.
Correct.
But like, how long should you wait when you first start dating somebody before you fart in front of them? And what is your best explanation if you do fart in front of them? Do you talk about FODMAPs? Or do you leave that out?
Okay, I'll tell you from my personal experience. One, you want to vet this person, right? Like, if you think that this person is the one, it's a good test. It's a good litmus test, right? Like, can you fart in front of them? Can it be after a full meal of whatever you really liked eating? If it was like a high FODMAP food, high steak food, high broccoli food, and then you farted, one, you gotta have to own up to it, right? And
Right.
two, you gotta vet them, be like, ooh, let's see their response.
How do you own up to it though? Do you just say, "Hey, I just let one loose"? Do you say, "I did
I mean,
one
it's.
cheek sneak"?
I think it's like,
Like,
yeah, yeah.
what do you do?
One, it's audibility and smell, right? Like if it smells like death, you're gonna have to own it, right? Like especially if the other person didn't. And audibility, right? Did they hear it? Like, did you just rip one? Because if you did, I don't think you're gonna be able to be like, that was a bird, that was a dog. Like, no, it wasn't. That was you, right? Like, did you hear it? If you didn't hear it, I guess you could pass it off. For example, if I'm in the endoscopy suite and obviously there's a patient that I'm scoping,
Yeah.
and if I've passed gas and I'm like, oh, I'm not.
You don't have to admit it because you're scoping them.
No, I'm scoping them. I'm like, God, this patient is awful. Like,
Can you
do
believe
smell
that?
this? Can you believe them? God, and like they've got CO2 gas being used, that's being expelled. So I 100% blame it on the patient.
100%.
100%, because then otherwise the anesthesiologist, the nurse, the tech, everyone's gonna be like, really? That was you? Like I can't believe it. But
It's so weird. Like the farting thing is so weird to me because sometimes like my wife would be like, "Why don't you go in the bathroom to fart?" And I'm like, "So what do you want to do? You want to go to the bathroom, fart, and then drag it all the way around the house, all the way out?"
Trapping.
Right?
Yeah, it's Dutch ovening her in a bathroom.
Right. I mean, well, like, what? But if I go in there and fart and shut the door, then I got the fart stank all over my clothes, and like, there's just like, I just think farting, you just got to let it go. One of the reasons I started like paying for myself to fly like first class, like across to different countries, is because like I want to fart in peace, bro. Like I just want to let it go.
Mhm.
Like hopefully the flight attendant doesn't walk by me and offer me a drink when I just let one go. But actually, I was on the way home from Nashville yesterday or the day before, and I was sitting first class, and I don't know, I ate something with some FODMAPs or some shit, and like I let one go, right? And I kind of like did like one of these. I was, the plane's like, shh, and I'm just like,
Yep. Mm-hmm. Mm-hmm.
and then it's like, right? You're just like, oh crap, right? I'm like, oh crap, like what's going on here? And I'm hoping, because the guy next to me has his AirPods in, so he doesn't hear me, thank God, right? But then the flight attendant's like, oh sir, can I get you something else? And I'm like, nope, I'm good. Like, turn around, go the other way, right? Anyway, I don't know. Like, farts are fascinating, I guess.
They are fascinating. You fart more when you're on airplanes because of the abdominal pressure building up.
Is that right?
Yes.
Oh my God, what a myth. Myth bust. Well, okay, so you do fart more on airplanes.
You do fart more on airplanes.
That is why.
Yeah.
Oh my God. This is fascinating stuff.
Yeah.
So FODMAP diets, if you eat a low FODMAP diet, are you going to fart less?
So the idea is that you're having less of these fermentable sugars, right?
Yeah.
But you are cutting out a lot of the fiber, right? And so you may fart less, but you may also be eating other foods that are low FODMAP. So if you're having a high protein meal, right? So you're having a lot of chicken or a lot of beef, you're definitely going to be still farting a lot. So it's not necessarily dependent on whether or not you're having those veggies and fruits, but low FODMAP diet should only be done for 4 to 6 weeks, okay? The whole point is that you are eliminating these high FODMAP foods, these farty foods and veggies, and then you're introducing them one at a time back into your diet to see how you respond when you do introduce it back in, right? And so it's not a lifetime thing. I don't want people to be like, oh yeah, fix IBS with a low FODMAP diet. No. Try a low FODMAP diet to see if there are culprit foods that are your triggers, but your IBS is not being caused by food. Okay, your IBS is being caused by a visceral reaction from a miswiring of your gut-brain connection.
How do you treat IBS?
So it depends on the type of IBS you have.
Let's come up with a patient, say they got this IBS, this is what I'm doing.
Okay, so they've got IBS type C. Okay, you've got a 46-year-old woman who is coming in with infrequent poops and a lot of anxiety. And she is straining to go to the bathroom, goes maybe once every 4 days. She has abdominal pain right before she goes. She feels a lot better after she poops. And whenever she's stressed, she's not pooping. Okay, so when she travels, she's not pooping. This woman would do well with what we call GCC agonists, so like a medication like Trulance or Plecanatide or Linzess. There's one called lubiprostone. These are medications that are mimicking the natural pathways to create and move poop along.
So the motility medicines.
Motility medications, yes. And then I may also depending on how they do, may put them on a medication like Zoloft or SSRIs, because you've got happy serotonin receptors in your colon that not only help their anxiety and their stress, which is likely exacerbating their IBS, but also the serotonin in there is allowing for the poop to move along.
So listen, you guys, if you're having these types of symptoms, if you're having bloating, abdominal pain, you've got, a history of pelvic floor dysfunction or depression or anxiety, you very well could be having IBS. And like having a specialist like Dr. Patel in your life is probably necessary, right? Because hearing the types of medicines that she is using, these are medications that require some monitoring. They all have, not only their positive effects on your symptoms, but
Yep.
the side effects that we all think about on a
yeah.
daily basis.
Absolutely.
So you got to monitor those things. So my question for you now is there a patient that this patient came in, they were absolutely miserable, you treated them, and they are doing absolutely fantastic? Again, we call it a positive pulse, but I want to hear it from you. Like, is there a patient of yours that just comes to mind? You're like, man, I remember this dude and I really helped him out.
Yeah. A 53-year-old woman had come in. She had a baby about 3 years prior to coming to see me.
At 50?
Uh-huh.
Wow. Okay.
Yeah. She had an IVF baby.
Okay.
And, with being perimenopausal, so her hormones were declining, her pelvic floor had gotten weaker. And so she did give birth and was super happy that she had this baby. But, the stress of getting pregnant because she had to undergo IVF, the stress of keeping this baby alive and learning, new motherhood things at an older age, she was super stressed. She had bad postpartum depression. And the last thing she could think about was pooping. And so when she came to me, she was like, my life is a mess. I don't know why I did this. I had this baby super late in life. And, I can't poop anymore. I can't eat anymore. I can't think anymore. Like nothing is happening, right? And I remember just asking her just about her life and just what had transpired in the last year in her life, and just understanding, changes in her hormones, changes in her bowel habits, changes in her pelvic floor. It was easy for me to finally understand that her constipation had not improved. She's like, have been taking Miralax every day, and I've been taking Benefiber, like the fiber supplement every day, and nothing's happening. I'm like, yes, that's because your constipation is multifactorial, right? You've got bowels that are too stressed out and they're holding on with a death grip from all the stress you're having, right? That's the IBS type C. You've got postpartum depression where your serotonin and your happy hormone is depleted, so we need to give you that back. You've got pelvic floor that no longer is, pushing and squeezing out the same way because you pushed out a baby. And you've got, changes in your diet. So all in all, we gave her plecanatide. We gave her a low-dose SSRI to help her with her postpartum depression. We put her in pelvic floor physical therapy. And 6 months later, she was like, I feel like my old self again.
That's awesome.
And she's like, every other doctor I'd been to, they did my colonoscopy and they told me to have more Metamucil. I'm like, that's not going to change much, right? Like, if you're not addressing the underlying cause for the constipation, you're just kind of throwing things at it. So
it required your full understanding of what IBS is. Like when you read the Nature Disease Primer on IBS, obviously I read it before we had this chat. What you're describing is within that primer of the multiple factors that lead to this condition, right? The gut-brain communication, the epithelial and immune communication, the bacterial communication. And you're taking all of that knowledge and you're applying it to the patient, and the patient improves. And I think that's amazing.
Yeah.
No, I mean, I loved having you on the podcast today. I really appreciate you coming by.
Thank you.
The scrubs that you wore, awesome, right?
They are actually super comfortable.
They're super comfortable.
I love them.
They are. Where can we find you, Dr. Patel?
So you can visit my website, www.kumkumpatelmd.com. On Instagram, I'm dr.gutmotility_motility. And you can find me in Orange County in any of my 3 offices. If you go to my website, you can click and schedule an appointment with me directly.
You guys heard it from her first. We really appreciate you being here on The Health Exchange. Thanks for watching and listening. We're on Instagram at The Health Exchange Podcast. We're also on TikTok at The Health Exchange Podcast. Get us wherever you get your podcasts every Thursday at 6 a.m. Pacific, 9 a.m. Eastern. We'll see you next Thursday. Take care.